So Brett asked me to talk about cartilage lesion location and to be able to understand if they're all the same. So the answer is yes and no. Yes, because we have to follow the same principles to treat them. And those are, what is the least that I can do to make them better? What will provide the fastest recovery to that patient, and what will endure the loads imposed? As we've heard from the previous speakers, it's not the same to have a low demand or a high demand or a high level athlete. So the principles are the same. We treat people conservatively. They have an acute onset of their performance is maintained, and we treat them surgically when they have failed non-operative treatment, when it's affecting their lifestyle, and when they have impaired performance for high-level athletes. We always have to think, we always talk about surgery and what's the best treatment for this or that type of lesion, but we have to remember that there's a return to the mean concept when we're treating cartilage injuries as well as osteoarthritis, where you can see that some people would have a flare-up and they will go back to a baseline. And that baseline might not be the same where they started, but they will go back to a baseline. So it's always important to give them time to see if they will actually need any sort of surgical treatment. What are the surgical treatments, non-surgical treatments that we have available? One is do nothing, skillful neglect. If you just give them time, 6 weeks of physical therapy, or just even time and anti-inflammatories, they might get better. Injection to treat the inflammatory mediators if need be. I'm not saying just cortisone, but sometimes any sort of AHA or PRP might be okay to treat smaller injuries. And physical therapy, of course, to work on strengthening of a VMO, for example, if they have a patellofemoral injury and so forth. So this is something that we should be thinking about when we see these patients for the first time in clinic. Now, if you need to treat them surgically, be minimalistic. We don't need to jump to a very large procedure and replace the cartilage and do a MACI biopsy that might be too expensive. A debridement can be okay in 70% of the patients, and this allows you to know exactly where the lesion is. As we were hearing from previous speakers, usually MRIs underestimate the size of the chondral lesions, and we sometimes don't see exactly what's going on the tibial side, how's the meniscus pathology. So at first, a diagnostic arthroscopy debridement only might get you out of trouble in 7 out of 10 cases, so it's not negligible. Now, if you have to go further down the line, well, you can start looking at all these options. And as you know, if you replace cartilage with cartilage, that's going to be your best bet. So what to do, I'm going to try to present an algorithm here, which is basically what I use in my mind to try to decide what to do. One, if it's a very high level athlete, you have to see where in the season are they, because you can't be too aggressive at the beginning of the season. You want to let them play as much as you can, and then probably treat them at the end of the season. And these are the 4 things that I always think about. Alignment is the first thing that I think about, not only in tibiofemoral joint issues, but also in the patellofemoral joint, because I want to make sure that I'm going to give that cartilage repair, or even you might not need a cartilage repair procedure just by doing an osteotomy. The second thing is a degree of osteoarthritis. The third thing is the size of the lesion, as we just heard. And the final thing is location, which is what I'm going to talk about. And that's how I build basically my algorithm. If you have a pretty bad alignment or alignment that is completely off, then osteotomy might be all that they need. If they have too much arthritis and debridement, if they have a small size injury, as we heard before, OATS or microfracture plus, and if it's large, then we see if it's a resurfacing procedure. If it's deeper, if it's a deeper lesion, we go with a more osteochondral type of repair. Where are the lesions? Mostly on the medial femoral condyle, as we've heard before as well, but it doesn't matter too much. You just need to have the principles. Let's go with patellofemoral joint consideration. Where is the problem? It's critical here. If it's inferior lateral, medial, or proximal or patellar, it's going to change significantly, as well as if the lesion is in the trochlea. So a focus on osteotomy will give you great results by itself if the lesion is inferior lateral, 55% success if it's medial, and 20% if it's proximal or patellar, and almost 0 if it's associated with a bipolar lesion on the trochlea. Now, if it's inferior lateral, if you just do an AMC, as we said before, if the TTG is over 15 millimeters, you can achieve pretty good outcomes. As we said before, 87% success with only an AMC. So in those people, you can unload them pretty safely. If it's medial or proximal, even if you do an AMC, it's not going to be probably enough. So you try to do this as vertical as you can of a cut. I usually use a guide to get to 60 degrees. So it's almost splitting the tibia in half. And that's going to give you some more relief of that anteriorization. But you also need to add some cartilage procedures at this point, because you're only going to get 75% good outcomes when you do it this way. But when we talk about cartilage procedures, in addition to osteotomies, or like a full course osteotomy or an AMC, what do we need to do? And this is something that they previously described in previous talks. If you have a very small lesion, microfracture plus on the patellofemoral joint, be very careful. Oats is another option. If you have more than 2 centimeters, if it's deeper, if it's a revision, or if it's a bipolar injury, I usually will use an osteochondral allograft. And if it's superficial, you can use any resurfacing procedure. Macy is my go-to procedure. And if it's oblong, I would also use this type of technology, because I don't want to take too much healthy cartilage from the rounds of the cartilage defect. As we were hearing from previous speakers, these lesions are never rounded or square. They're usually irregular, and you don't want to take too much cartilage that might be healthy. And this is a previous systematic review where we are seeing that microfractures are decreasing in number, and all the restorative procedures are increasing. And the reason why microfracture was so popular is because it's easy, it's cheap, it's available everywhere. But I would only perform it on the trochlea if need be. And the reason being is that on the patella, it's very technically difficult. It's difficult to create stable borders. It's difficult to create a perpendicular microfracture arthroscopically. It has fewer progenitor cells in the patella, and the shear forces will put at test the fibrocartilage that you will recreate. So this is something I would caution you about not doing potentially in the patella, because you might get less than optimal results. On the trochlea, the repair tissue, as we know, is fibrocartilage. The longevity, as we heard before, and this is good to keep repeating, worsen after 2 years, and the return to sports is 44%, which is less than optimal. Oats procedures for smaller lesions, as we heard greatly from Deepak. It's hard to do this in a very large lesion, and you have sometimes breakage of the osteochondral plugs, and that can be a significant problem at the time of surgery. You have donor side morbidity, multiple plugs can be an issue. There's different cartilage thickness on the patella and in the tibiofemoral joint, and therefore you're going to have a mismatch there. And it's also very hard bone, so it's challenging actually to do as a procedure. Osteochondral allografts, we've published this on the tibiofemoral joint and on the patellofemoral joint. Survivorship is around 77% at 10 years. So it's, from a cartilage repair standpoint, one of the most long-standing cartilage processes or procedures that we can perform. It's challenging sometimes, mostly on the patellofemoral joint, because matching the anatomy and the curvature of the trochlea can be difficult, and sometimes overstaffing in a thin host patella can be also difficult. This is the de novo material. It's particulated juvenile allograft. It's very easy to perform. It can be performed in small to medium contained lesions. It's important that they are contained. It's challenging from an insurance standpoint, at least here in the US, because it's hard to get it approved. It has been shown to have really good outcomes, but you have to be careful, because some series have demonstrated hypertrophic cartilage repair when you overstuff the lesions, and therefore you have to make sure that they're basically at the level or below the level of the cartilage injury. This is a systematic review from Colorado University, 10 studies on Macy, both in the tibiofemoral joint and the patellofemoral joint defects, all improved PROs with only 7% failure. One thing that was actually pretty good to know was that the failure was significantly higher in the tibiofemoral joint than in the patellofemoral joint. Usually most of the things that we will see have worse outcomes in the patellofemoral joint. But can they return to sports? 73% of these patients could return to sport in this series. And this author suggested that a return to low to moderate activity is something realistic that we can tell patients that they can get back to. How about the tibiofemoral joint? As we know, when you compare microfracture to any sort of restorative procedure of the cartilage, they will do better when you do something like Oats or OCA. both for pain scores and also for activity levels. Now, is there any way that we can do microfracture better? Probably yes. As you can see on the left-hand side, you have a traditional microfracture with an awl. On the right-hand side, you have a newer type of technique with a micro drilling. And in this, histologic cut, you can see that a microfracture with an awl can cause significant bone marrow or bone reaction to that microfracture. And you can see that all the channels have been closed basically because they created an sclerotic process around the microfracture. Whereas if you drill, you still have those bone marrow channels open. And they have shown to not create healing necrosis, and therefore they might have better outcomes. We have a paper coming in arthroscopy that shows that micro drilling has significantly better outcomes than microfracture with an awl. So this is something to consider when you're performing this procedure. Are there any consequences of doing a microfracture? Yes. If you do it the traditional way, you have 2.45 times more chances of failure rate if you do a resurfacing procedure down the line. So be careful because you might affect your future outcomes. Oats, as we said before, for small injuries have good to excellent results in femur and results in high return to sport rates. On the tibiofemoral joint, again, really low reoperation rate down the line. So this is something we should consider. This is showing again that OCA can be a very good treatment for injuries in the tibiofemoral joint as well, 80% at 10 years survivorship. And can they return to sport? Two series, one from our university here at Rush and one from San Diego, Bill Buckby, 75 to 77% return to sport rate, which is pretty phenomenal for a cartilage restoration procedure. ACI, some articles say that it's better in the tibiofemoral joint. Some articles say that it's better on the patella, but overall, pretty good outcomes on both patient samples. Now, one thing that we need to know is that sometimes all the restorative procedures that are resurfacing procedures such as MACI might take a little bit longer to achieve those outcomes. And this is what we've seen in our series where patients that have an OCA might get better sooner, although at 2 years, the outcomes are the same as MACI. In the tibia, I recently started using this procedure, which I found to be fairly reliable. I harvest the cartilage from the notch using a net in my shaver, and then I mix this cartilage, the autologous cartilage, with BMAC, as well as glue at the end to make it sit on the defect. I distend the joint using water at the beginning, but then CO2 so that it's completely dry and the lesion is dry. I make these microfractures with a drill. These injuries are very hard to get to, and that's why I think this technique is actually a good technique to repair this type of procedure. You can see here, using CO2, you have a perfect distension, and you can see pretty well. You can see the autologous cartilage surrounded with BMAC and then glue at the end to aid in a pretty good repair. So in conclusion, be minimalistic, try non-op first, respect the general principles regardless of the fact that it might be on the tibiofemoral joint, on the patellofemoral joint. Osteotomies are the key sometimes when there's malalignment, and depending on where it is on the patellofemoral joint, you have to be thinking of an AMC that might be more vertical or not. And if you have patellofemoral tibial cartilage repair procedures, you can expect to achieve excellent outcomes and great return to sports rates if you use the right technique. Thank you very much.